Hello, everyone. I am Dr. Tatiana Kelil. I'm an assistant professor of radiology at UCSF, and I'm very excited to be presenting this lecture on breast MRI for you today in collaboration with Health4TheWorld.org. Just a quick introduction about myself. Like I said, I'm an assistant professor of radiology at UCSF. I earned my medical degree from Chicago Medical School, followed by diagnostic radiology residency at Brigham and Women's Hospital at Harvard Medical School, and then completed a women's imaging fellowship at UCSF, where I currently serve as a faculty. I do not have any disclosures or conflict of interest, but I would like to acknowledge my colleagues, Dr. Heather Greenwood and Dr. Bonnie Jo, for their contribution to this presentation. So today we're going to go over breast MRI, and the topics that we will be covering would include indications for breast MRI, the MRI report structure per BI-RADS criteria. Then we'll go over findings, including abnormal enhancement and how to assess an abnormal finding on MRI. We'll go over kinetic curve assessment. And finally, we'll talk about giving an overall impression and assessment category and recommendations to your clinicians. So the learning objectives at the end of the lecture, hopefully you would be able to identify indications for breast MRI, become familiar with BI-RADS reporting and structure your MRI report, identify abnormal findings on MRI, and give final assessment and recommendations. So we'll get started. If you haven't seen an MRI machine before, this is what it would look like. For breast MRI, the patient is going to be facing down with the head here and the breast in a prone position. We use a breast-specific coil to get the best signal. And at UCSF, this is the protocol that we use. These are the sequences we will be obtaining for breast MRI. If it was for cancer assessment, if it was for implant evaluation, then a contrast will not be used. But for screening and diagnosing of cancer, these are the sequences we normally obtain: T1 non-fat suppressed before contrast, T2 fat suppressed before giving contrast, and then again pre and post contrast T1 fat suppressed images. So we usually get 7 phases of T1 fat suppressed images after contrast is given. We use IV gadolinium for contrast, which is the usual dose of 0.1 millimole per kilogram, given at 1 to 2 mLs per second, and followed by around 10 ml of saline flush. So what are the indications for breast MRI? One of the major indications is for screening. Both the American College of Radiology and American Cancer Society recommend screening MRI for high-risk patients. This includes women with greater than 20% lifetime risk of breast cancer, so patients with BRCA mutation, or if they have a first-degree relative with BRCA mutation, even if they're untested, or if the patient had a history of chest radiation between the ages of 10 and 30, or any of these genetic conditions like Luframani or Cowden, then high-risk screening MRI is recommended for these patients. The American College of Radiology also recently updated their screening recommendations for intermediate risk patients. These are patients with a lifetime risk of 15 to 20% and includes patients with prior personal history of breast cancer and dense breast tissue, or if their cancer was diagnosed before the age of 50. For these patients, MRI is recommended. And if the patient has a history of breast cancer and one of the atypical or high-risk lesions on pathology, such as lobular carcinoma in situ, atypical ductal hyperplasia, or ALH, for these patients, MRI should also be considered, especially if other risk factors are present. ACR does not recommend screening MRI for patients with average risk or if they're asymptomatic. It's important to note that the American Cancer Society currently does not have enough evidence to recommend either for or against moderate risk patient screening, and does not recommend screening MRI for average risk patients, just like ACR. Another important point to note is that breast MRI screening is an adjunctive mammography, meaning it does not replace mammography. At UCSF, what we do is alternate MR and mammography every 6 months. So other than screening, what are the indications for breast MRI? One thing you can use it for is if there's a known cancer, you can use MRI to evaluate the extent of disease. For instance, is there any invasion of the pectoral muscle? Because that would help the surgeon decide, the extent of surgery that needs to be done. So in this case, for instance, you see the mass, but in addition to the mass, it also extends to the pectoralis muscle, and you see enhancement of the pectoralis muscle. And this is important to note to the surgeon. MRI can also help you assess whether the disease is multicentric or multifocal, because again, that's going to determine management routes that the surgeon is going to take. So in this case, the MRI showed these abnormal enhancing masses in different quadrants of the breast and also extending to the nipple. So again, that is an advantage of MRI because it shows you the extent of disease. Another indication is to evaluate treatment response in patients receiving neoadjuvant chemotherapy. I'll show you an example here. This was a patient that had invasive ductal carcinoma, and you see these two large enhancing masses. And this was obtained in 2018. And after a few months of chemotherapy, you can see that the enhancement has basically resolved, meaning the patient was responding to treatment. So MRI would help you assess treatment in the population that's receiving neoadjuvant chemotherapy. Another indication is to evaluate axillary or distant metastasis with unknown primary. Let's say if a patient presents with axillary lymphadenopathy, either clinically palpated or found on imaging, but there is no primary identified on mammography or ultrasound, MRI can be used to problem solve. So this was a patient that presented with, you can see these enlarged abnormal looking lymph nodes in the right axilla. But the mammography and ultrasound images did not show where the primary tumor was located, and the MR showed this tiny focus of IDC, which was biopsied under MR-guided biopsy, so we could know where the primary disease was located. MRI can also be used to screen the contralateral breast in newly diagnosed breast cancer. Here's an example of a patient with known left-sided breast cancer. Here you can see an irregular spiculated enhancing mass, really suspicious. There's a biopsy clip in the middle. So this patient had known cancer on the left side, but then we obtained the MRI, and then again you see another abnormal and non-mass enhancement on the contralateral side, which was not detected on ultrasound or mammography. So again, MRI is important for detecting occult contralateral disease in about 3 to 5% of the cases. In the ipsilateral breast, again, you can use MRI to identify occult disease. This was another patient that had, again, suspicious mass that was biopsied and proven to be intraductal carcinoma, invasive ductal carcinoma. And the MRI showed an additional focus, which was not visible on mammography or ultrasound. MRI can also be used to assess patients with positive margin post-lumpectomy. Another indication is to evaluate for recurrence of breast cancer, especially when mammogram and ultrasound are inconclusive, or in patients who have had tissue reconstruction, and if it is difficult to differentiate fat necrosis from recurrence, MRI may be useful to problem solve those cases. So this was a patient that had mastectomy with tram flap reconstruction, presented with a palpable lump. But as you can see, she has a lot of fat necrosis, and it is difficult to see what's fat necrosis versus if there's anything suspicious underlying. So we obtain an MRI, and you see the fat necrosis because it's following fat signal on the T1 non-fat suppressed images here. But then in addition to the fat necrosis corresponding to this finding, you can also see an enhancing spiculated mass, which was suspicious, got biopsied, and it came back as recurrent invasive ductal carcinoma. Here's another example showing recurrence in a tram flap reconstruction on the left breast right here. MRI is also useful in patients with breast augmentation in whom mammography is difficult, especially patients that have free silicone or paraffin injection. Here you can see this patient has had a silicone injection for breast augmentation, and the silicone granuloma, this dense white stuff, is obscuring any potential malignancy. And it's difficult to interpret this mammography. But then we obtained an MRI, and you can see there was no suspicious finding. However, the silicone granulomas are not going to be obscuring disease if there was one. So in these cases, MRI is useful. And finally, MRI can be used for MR-guided biopsy if the lesions are called on mammography or ultrasound. So here's an example of a finding that's only visible on MRI that we used MRI for MRI-guided biopsy. So we're going to move on to the breast MR report structure. For every report, you want to include a concise clinical history or the indication for the exam. So that would include if there's any symptoms such as breast pain or palpable lump or nipple discharge. So any of the symptoms should be included. And any prior history of breast cancer, or if the patient had prior surgery, or if the patient has a family history of breast cancer, all of those are going to help you create a holistic report. So all of those indications should be listed. Then the exam would be compared to old studies because it's important to know what's new, what has been stable over the years. So you want to compare all your exams to prior studies. And the acquisition parameters should also be listed. So what sequences were obtained, what kind of contrast agent was used, what was the dose, if there was any post-processing done. So those things should also be reported. And then finally, you'll jot down your findings. We'll go over in detail what abnormal findings you might be able to see on an MRI. And finally, you want to give an overall assessment and category with recommendations for your referring clinicians. So the first thing you want to note is the amount of fibroglandular tissue that describes the overall breast composition, and it can be one of these 4 categories. So this is what an almost entirely fatty breast would look like. There's barely any fibroglandular tissue. Here's a scattered fibroglandular tissue breast. There are scattered areas that have fibroglandular tissue, but the majority of the breast is still fatty. Heterogeneous fibroglandular tissue is, the majority of the breast is fibroglandular tissue, and there's limited amount of fatty tissue. And extreme fibroglandular tissue breast is almost all composed of fibroglandular tissue. And on mammography, this is, what we would call extremely dense breast, and that would obscure underlying masses. But on MRI, you don't have that problem, meaning even in dense breasts, if there's an enhancing mass, you're going to be able to see the finding. After noting the amount of fibroglandular tissue, then you want to describe the background parenchymal enhancement, or BPE. BPE describes the percentage of enhancing fibroglandular tissue. So in relation to the rest of the surrounding normal breast parenchyma, how much is the fibroglandular tissue enhancing? Assessment usually occurs on the first post-contrast image, usually obtained around 90 seconds after contrast injection, and the levels can be minimal. Here's the breast showing minimal background enhancement, meaning there's barely any background enhancement. Here's what a mild BPE would look like. Moderate, and then marked, basically there's significant amount of background parenchymal enhancement. An important point to note is that background enhancement is not the same thing as density. So you can have a patient with dense breast, meaning extremely fibroglandular tissue, with minimal background enhancement. So those 2 things are not related. So you can have a dense tissue, but not that much background parenchymal enhancement. BPE also varies with hormonal changes. For instance, with hormone replacement therapy, you might see it being more prominent or less prominent with tamoxifen treatment. And one other important point to mention is, in general, BPE is more prominent in the luteal phase of the cycle, especially if the patient is premenopausal. So the recommended time for imaging a patient for screening is around the 2nd week of the menstrual cycle. If the patient has a cancer diagnosis and you're obtaining the study for evaluation of extent of disease or to screen the contralateral breast, you can do it at any time. But especially if it's for high-risk screening, you want to optimize the time of the time that the study is obtained, so that you're not calling background parenchymal enhancement as an abnormal finding. Another thing to note is whether the BPE is symmetric or asymmetric. Symmetric BPE is benign. If it's asymmetric, it can be benign or malignant. So you should always review the clinical history and look at the mammogram and ultrasound to see if there's any cause for the asymmetry, because the positive predictive value for malignancy when you see an asymmetric BPE is around 14%. But there are some benign causes that can cause asymmetric BPE, especially if the patient had prior radiation therapy. Here's an example of a patient with prior radiation therapy to the left breast. So there's decreased BPE there, and you can see that the right breast has an asymmetric marked BPE. Or if the patient has mastitis or infection of the breast, you can see an asymmetric BPE. But if the history and the prior images don't indicate, a plausible cause for asymmetric BPE, you should be suspicious for malignancy as the cause. Next, we'll move on to abnormal enhancement. So what are the abnormal enhancements you might see on an MR study? So abnormal enhancement is described as enhancement which is greater than the surrounding normal BPE. And this can include a focus, a mass, or a non-mass enhancement, and we'll go through each of these. A focus is an abnormal enhancement that's too small to further characterize, and it's usually less than 5 millimeters. So it's too small for you to describe the margins or the shape, but it is unique from background parenchymal enhancement, and there's no corresponding finding on the pre-contrast scan. A mass is, in contrast, a 3D space-occupying structure with convex outward contour. It may or may not displace the normal surrounding breast tissue. So here's an example of a mass. It's convex outward contour, you can see here, and it is a 3D space-occupying lesion, and you can describe its shape and margin. So the next thing you want to describe is the shape of the mass. So it could either be round, which is spherical, or oval, which is elliptical or egg-shaped. Or if it has a gentle 2 to 3 undulations, you can also include that under oval. If it's neither round or oval, then it is going to be described as irregular. And here's an example of what that might look like. Once you describe the shape, then you want to analyze the margin. So it can either be circumscribed, and usually these are considered benign. There are circumscribed masses that could be malignant, but in general, our suspicion is higher when it is either irregular or spiculated. But again, you take a number of things into consideration, so you can't just decide benign versus malignant based on the margin, but you take all of those factors into account. And after describing the shape and margin, then you want to describe the internal enhancement. So it could either be one of these 4 findings. Homogeneous, here's an example. There's a contour and uniform enhancement. Heterogeneous internal enhancement describes a non-uniform enhancement. As you can see on the image here, there's an area that's not enhancing that much, and then there's an area that's enhancing vividly, so there's a non-uniform enhancement. Rim enhancement, you have more pronounced enhancement at the periphery, and a number of things can cause this. For instance, if there's an inflamed cyst, you would see peripheral enhancement around the cyst, but to confirm that it's a cyst, you can go and look at the bright T2 sequences where the cyst would be bright. Another finding that would give you rim enhancement is fat necrosis, which is shown on the example here. But if you go and look at the fat non-suppressed T1 images, you can see that the inside the mass, it is following fat signal, indicating this is fat necrosis. But malignant etiologies can also cause rim enhancement. This is invasive ductal carcinoma, which was centrally necrotic. So the central part of the mass is not enhancing, but there is a peripheral rim enhancement, and this was biopsied and shown to be invasive ductal carcinoma. Another type of internal enhancement is dark internal septations. You see non-enhancing lines within a mass. This usually indicates a fibroadenoma, but it's not pathognomonic. meaning if you see other features that are suspicious, or if the kinetic curve assessment shows that the mass is suspicious, it might still need to be biopsied, but usually we see dark internal septations with fibroadenoma. So we've looked at focus and mass, and now we'll move to the third type of abnormal enhancement, which is non-mass enhancement, or NME. That is enhancement that's neither a focus nor a mass, but the pattern is discrete from normal surrounding parenchyma. So here you see an example of non-mass enhancement. It's not really a mass or a focus, it's occupying a large part of the breast, and that's what we would describe as NME. So once you identify an NME, you want to describe the distribution. So it can be focal, which is confined to an area which is less than 25% of a quadrant, as you can see here. It could be linear, as the name implies, enhancement in a line. It could be segmental, or a triangular region of enhancement with the apex pointing towards the nipple. This is usually a suspicious finding because it indicates that this abnormal process is following a ductal pattern. Another form of distribution is regional, when the enhancement is in a large volume of tissue not conforming to a ductal distribution and tends to be geographic. Or you can see NME in multiple regions of the breast, or it can be diffuse and affect almost the entire breast. Once you describe the distribution, the next thing you want to analyze is the internal enhancement pattern. Just like we did with masses, it could be homogeneous, which is confluent uniform enhancement, or heterogeneous, non-uniform enhancement in a random pattern. Clumped internal enhancement describes a cobblestone-like enhancement with occasional confluent areas. As you can see here, there's a more confluent region here, but then it skips and it's like a cobblestone appearance. Or you can have what's called a clustered ring that represents periductal enhancement. And this is a suspicious finding. The positive predictive value for malignancy is about 77%. So next, we want to look at kinetic curve assessment. So there are two portions to kinetic curve assessment. The initial enhancement phase happens within the first 2 minutes after contrast injection, or until peak enhancement is reached, and it's determined by comparing the intensity in the first post-contrast image to intensity in the pre-contrast image. So if the increase between the pre-contrast and the first post-contrast image is greater than 100%, we describe that as fast initial phase. If the difference is between 50 and 100%, we describe that as medium increase initial phase. Or if the increase is less than 50%, that's described as slow. And then you want to look at the delayed phase enhancement. What's the curve doing after the peak enhancement is reached, or after 2 minutes, what's the curve doing? So if it consistently rises, or if you see greater than 10% increase in enhancement, that's described persistent. If the change is between minus or plus or minus 10%, it's described as plateau. And if it decreases significantly after the peak is reached, or if the decline is greater than 10%, we call that a washout. And usually persistent is considered benign or not bad, and then plateau and washout are suspicious or bad. But again, that's an overgeneralization. There might be a malignancy with persistent enhancement kinetics. Or sometimes, for instance, a lymph node, which is a benign finding, might have a plateau or washout kinetics. So you can't just base it on the kinetic curve assessment. Like I said, you take a lot of things into consideration, the morphology, the distribution, and the kinetic curve assessment, and you kind of put those things together to decide whether a finding is suspicious or not suspicious. But just in general, persistent is usually considered not as concerning, and washout and plateau are concerning. So here's an example of what a type 1 or persistent curve would look like. So you have the initial peak and then it keeps rising. And on the images, there's the finding. it enhances, and then after 2 minutes, it continues to enhance. So this is a persistent curve. A plateau curve, there's the initial rise, but then there is no significant change in the enhancement pattern after the first 2 minutes. Or if you look at the images, there's a finding, it enhances, continues to enhance, but after the 2 minutes, there's no significant change and it plateaus. For washout, there's the initial rise, but then after the 2 minutes is reached, there is a decline in degree of intensity of enhancement. So you see this finding, it enhances initially, but then after 2 minutes, the contrast completely washes out. So this is a suspicious finding. So once you have described your abnormal enhancement findings on the MRI, then you want to look for associated features. So these are features either standing on their own or in addition to other findings that you've seen, raise your suspicion for cancer, or they might be related to prior surgery, but you just want to look for them and describe them. So I'll show you a few examples. Here's spiculated, enhancing, ugly looking mass, but you can see that it's tethering on the nipple and there's nipple and skin retraction. So you want to look for that and then report it when you see it. Same thing here. There's an abnormal enhancing spiculated mass and it's tugging on the nipple. So there's nipple and skin retraction. Nipple and skin invasion. It's important to note this because it might preclude the patient from getting a skin sparing mastectomy. So if you see the skin or the nipple enhancing or being invaded by the disease, it's important to mention that on your reports. Skin thickening and skin invasion again. Skin thickening can be due to skin invasion or it can be due to other benign etiologies. For instance, prior radiation therapy can cause skin thickening or mastitis. Axillary adenopathy, here's an example of abnormal lymph node. So you want to mention that in addition to the, this patient had inflammatory breast cancer, but which has metastasized to the right axillary lymph nodes. And you want to also mention if there's, like I mentioned at the beginning, if there's any pectoralis muscle or chest wall invasion, because that would change the management options that the patient might have. So you want to look for that and report that. So you can also have non-enhancing findings that are not enhancing on the post-contrast images. One of these is a ductal pre-contrast high signal on T1, meaning on the post-contrast images, there's no enhancement, but on the pre-contrast images, you'll see this T1 high signal, and this is usually to proteinaceous content within the ducts or blood within the ducts. But when you look at the subtraction images where you subtract the pre-contrast image from the post-contrast image, you see that there's no intrinsic enhancement and the bright signal was just from the proteinaceous or bloody content within the ducts. Here's another example. It was, the T1 images showed a bright ducts, but when you do the subtraction, there's no real enhancement. Cysts are other findings which are non-enhancing usually, and they're circumscribed, fluid-filled, and you might occasionally have peripheral enhancement, especially if the cyst is inflamed, but the center should not be enhancing, and the walls should be thin and imperceptible. So this is a benign finding. You can have hematoma or seroma in a patient that has had surgery or a biopsy, and this could be simple or complicated and maybe bright on the T1 images due to blood, but should not enhance on the post-contrast images. So here's an example where you see T1 bright circumscribed mass, and then on the post, it appears that it's enhancing, but when you do the subtraction, there's no real enhancement, and this brightness was due to the intrinsic T1 bright signal due to hematoma. So this was post-operative seroma containing some hematoma. And you can have skin thickening, again, unrelated to malignancy, especially if the patient had prior radiation treatment. You can see this right breast has asymmetrically thickened skin. You can also have fat-containing lesions. Lymph nodes are fat-containing lesions, and you can see the fatty hilum on the T1 images. Lymph nodes can be normal or abnormal, so you would base that on the morphology and the size. Fat necrosis is another fat-containing lesion. We saw an example earlier with the rim-enhancing lesions centrally following the fat signal on all sequences. Hamartoma can contain fat, so that could present as a fat-containing lesion, or postoperative seroma with fat can contain fat. So now we move on to impression. We've described all the findings that you might be able to see on an MRI. Impression is your overall summary that you would give to the clinician. So you want to give an assessment category based on BI-RADS, and we'll go over that. In addition, if there's any imaging recommended, you want to provide suggestions for the next course of action. So you want to guide your clinicians what to do next after you give the assessment. For a BI-RADS for a suspicious lesion, if there's no, so you want to recommend a second look ultrasound instead of going directly to MRI guided biopsy, because ultrasound guided biopsy is more comfortable for the patient, it's less expensive, it's readily available. So if the mass is large enough to be seen on ultrasound, you want to recommend ultrasound guided biopsy. But if there's no sonographic correlate, then you can move on to MR guided biopsy of the finding. BI-RADS assessment categories are based on BI-RADS lexicon for mammography, or it's similar to BI-RADS categories for mammography. Category 0 implies that additional imaging evaluation is needed before you can make any recommendations. At UCSF, we almost never use this unless there was some technical difficulty that prompted the study to be repeated, but otherwise we usually make our determination based on the images that we have. Category 1 describes a negative exam, so there was no finding to be reported and the exam is negative for cancer. Category 2 implies that there were some benign findings that you chose to describe, such as cysts, non-enhancing scars, or if the patient had a breast implant. But both for category 1 and category 2, the conclusion is that there's no MR evidence of malignancy. Category 3 is probably benign. There's a less than 2% chance or likelihood of malignancy. We use that in mammography and ultrasound as well. But for MRI, there's limited data currently to guide us which findings should be categorized under probably benign category. So at this point in time, we don't use category 3 at UCSF, other institutions do. But once more data becomes available, I'm sure we'll categorize some findings under this category. Category 4 is suspicious finding. There's a low to moderate probability of being malignant. So there's a greater than 2%, but less than 95% likelihood of malignancy. And for this, the recommendation is tissue sampling. So you want to biopsy, if there's a sonographic correlate, you want to biopsy it under ultrasound. And if not, you want to biopsy the finding under MRI guidance. Category 5 is highly suggestive of malignancy. So this is almost certainly malignant. There's a greater than 95% likelihood of malignancy. And for this, if the pathology result comes back as benign, you would not accept it, and you would either recommend repeat biopsy or surgical excision. Category 6 is used for known biopsy-proven malignancy. If a suspicious lesion is found in a patient that has known malignancy, that should be worked up. So you want to categorize that as category 4 or 5 as appropriate and not 6. The 6 is used for biopsy-proven malignancy and the patient is already on treatment plan. But if you see an additional finding in addition to the known cancer, you want to categorize that as 4 or 5 and have the appropriate biopsy performed before proceeding with the treatment for the known cancer. So the take-home messages are MRI is an adjunct to mammography. So it's a very robust tool, but it does not replace mammography. And it's not always available in all parts of the world. So while it's really important to know how to read an MRI, or we should recommend MRI to the appropriate population of patients when available, but you should remember that it's an adjunct to mammography and it does not replace mammography. MRI interpretation follows a systematic approach. So we looked at how you evaluate step by step, put all of your findings together to come to a conclusion. So you want to look at how much fibroglandular tissue there is, what the background parenchymal enhancement level is, whether it's symmetric or not. And then you want to look for your abnormal enhancement or abnormal enhancing findings. Describe the shape, morphology, distribution. Look into the history to see if there's anything that explains any of the associated features like skin thickening or asymmetric enhancement of the breast. And then finally, you want to assess the kinetic curve, how the curve behaves, and come up with an overall impression. Another important point that I want to emphasize is that morphology trumps kinetic curve assessment, meaning if the mass has suspicious morphologic features, even if the kinetic curve assessment is reassuring, you should still categorize that finding as suspicious, because you should go with the most suspicious feature, even if the kinetic curve assessment is persistent or benign appearing. You should go with the most suspicious feature. Finally, once you take everything into account, you want to give a final assessment category and recommendation for each breast. So just as a review, BI-RADS 0 or category 0 is when you need additional imaging. Usually we don't use that for MRI, but for some reason, if there was technical difficulty, you want to recommend the patient to come back to get the additional images. Category 1 is for negative exams. There was nothing that you needed to mention. Category 2 is benign. So like a cyst, implant, something you mentioned, but there's no evidence of breast cancer is the conclusion. Category 3 is for probably benign findings that have a less than 2% likelihood of being malignant. We usually don't use that on MR, but in the future, once enough data is available, we're all going to be using that. Category 4 is for suspicious findings that prompt biopsy recommendation. Category 5 is highly suggestive of malignancy, and if a benign finding returns, you will not accept that. Category 6 is for patients with known malignancy, but if they have an additional site of suspicious finding, that should be categorized as 4 or 5. That is all I have for you today. Thank you for your attention. And if you have any questions and would like to reach out, here's my email address.